and Professor Sanjeeva to proceed with the session.
Yeah, thank you very much. Thank you for the lovely introduction to everybody. It's a great pleasure to start off the session today with Pablo Gonzalez, who is a real expert, as we've discussed in neuroanatomy. We're talking about white fiber anatomy, which is an area of real interest for him. Pablo, thank you very much for joining us today, and we look forward to your talk.
Thank you. Can you hear me properly?
Yes.
So thank you, Imad, for creating this experience. This is the first one, and if it works, I really hope we can do it in the future. And well, one of my passions in our specialty, it's the study of neuroanatomy in general, but more focused on white matter fibers. So I'm going to share part of my work with you. And the limbic area is something that I really wanted to understand when I was a trainee, because it's something complex, not only in name, but mainly in understanding how tumors in that area are growing. And I cannot start this talk without thanking whom I consider my mentor, who is Professor Ture. I had the privilege to stay in his beautiful hospital and microneurosurgery lab for 1 year, and that was a fantastic period in my life, who really changed my practice. So I highly recommend all of you to spend some time in the lab, because after staying in the lab, you can look at an MRI and see completely different things than the ones you see before. So first concept is to understand the word limbus, and the limbus means the edge. So the limbic system could be considered the edge, the medial edge, in fact, of our brain hemisphere. So this is the first concept I want to introduce. And the second one is why these areas are on the edge of the hemisphere. And this is something amazing. I also recommend you to study the phylogenetic evolution of the CNS, because this is a fantastic way to understand how the tumors are being located in these deep regions. So in 500 million years, the brains of the first animals, the fishes, became in what we have now. And if we analyze the evolution of this CNS growing, we will see in green areas, the limbic areas, the archipallial and some of the paleopallial regions, which with the development of the CNS are being pushed, as you can see, to the medial aspect of the hemisphere. And this movement to the midline is mainly due to the huge growing of the neocortex. So in this picture, in this coronal cut, we can see in red the neocortex and how these limbic areas have been pushed to the medial aspect, to the interhemispheric fissure, and also in the basolateral part where the parahippocampal regions are staying. So this evolution of the CNS is very important in order to understand why we have these limbic regions in the midline. So in these areas, we can find completely different tumors, mainly gliomas, low grade, high grade, even some mets in these regions. And my point is to try to share with you how I think about approaching, why I do the approaches I'm doing to reach these regions. So we will divide them in the cingulate area and the parahippocampal region. So you can see in this picture the subcallosal region, the cingulate gyrus, the isthmus, which is a very important part of the limbic system. It's a pivotal point in between the cingulate gyrus and the parahippocampal gyrus, which goes to the basal aspect and a little bit lateral because of the growing of the diencephalon in between both parahippocampal regions. So something important about the limbic system is not only this deep anatomy, this deep located anatomy, but also how the fibers are arranged. And they are mainly arranged like belts. They are completely different to the fiber systems we do have related to the telencephalic neocortical regions. This is very important. Another important thing is the vascularization of these regions, which comes directly from small perforators coming from the main trunks of the anterior and posterior circulation systems. So let's go about to deal out how I approach these regions and why, and mainly the choice of the approach should be based on anatomy. So we must consider go, respect, and perform. We have to go through anatomical corridors. We have to try to respect the surrounding structures, and we have to try to perform an atraumatic manipulation of the brain tissue, which is in between our tumor and our corridor. How we go through anatomical corridors safely with neuroanatomy, this is the key. How we try to respect the surrounding structures, understanding the tumor biology, how the tumor is growing and how it's being fed, and how we do perform a traumatic manipulation, choosing the proper approach and positioning properly our patients. But two very important roles in my mind to approach intrinsic brain tumors is to enter the sick functional unit, which means the most cortical aspect of any given tumor, and always try to stay within the tumor. And these are two concepts that I got from Professor Ture and Professor Yazargil during my stay in Istanbul. So let's go through some practical cases in order to highlight all these concepts. And this is a patient who we received 2 weeks ago in our department. He came with a headache and some personality disturbances, and you can see this low-grade glioma, how it's growing mainly in the subcallosal area. So first step is identifying where the tumor is growing. Subcallosal area is in the midline, it's the most basal and anterior part of the limbic system, just below the rostrum and genu of the corpus callosum, as you can see in this sagittal section. So in these cases, I like to, as I told you, to approach directly to enter the cortex in the point in which the tumor is more cortical, more superficial. So for that, I place the patient in a kind of semilateral position. It's a supine position with the head rotated slightly to the ipsilateral side. So you can see here the midline, and we, first of all, before opening the dura, must identify some veins, bridging veins, and the idea in most of the cases is to try to respect them. Sometimes the venous anatomy is very capricious, and we can do an opening like this to work into two windows. So we are going basal, and then we enter the tumor in the most cortical part. So another important aspect is that this tumor was being pushed to the contralateral side. So this is why we can open the falx in this part and perform our subpial resection. Then we go deep, and we want to identify the chiasm, that's the optic chiasm just below and behind the tumor, and also both A1s and A2s. It means that we have reached the most posterior part. Then we move upwards to enter the frontal horn. In this case, as it had hydrocephalus, we perform a septostomy. And as you can see, we are staying inside the tumor. That's the key in order to understand how these gliomas can be resected in the proper way. This is the post-op MRI. We had some doubts about the total removal, but the diffusion said that we had some ischemic areas, and we were quite happy with this result. He was discharged just last Friday. So this is a message. Not only think about the tumor, where is it located, but also in our corridor. And in our corridor, maybe we can find some of these bridging veins, because we have to approach the interhemispheric fissure. So it's important to try to respect them as much as we can. Let's go to this second case. This is a tumor. This is a GBM of a 53-year-old male who had some personality disturbances. And this case is mainly situated in the anterior cingulum. So this is why this tumor is growing like this, because the cingulate fibers are wrapping around the genu of the corpus callosum. So again, this is what we use in these cases, supine position with the head slightly rotated. And I took this very, very interesting positioning from Professor Mike Lawton. He was approaching basal ganglia cavernous malformations like this. So with this approach, we will be able to release some CSF from the pericallosal cistern and to have the aid of the gravity to create our space in order to reach the contralateral aspect. So this is a interhemispheric contralateral transfalcine approach in order to reach this contralateral cingulate tumor. Again, we try to respect the venous anatomy when we are opening the dura. This is something mandatory, in my opinion, and to create as much space as you can. Releasing CSF will help us, and then we can open the falx, protect the ipsilateral hemisphere with some cottonoids and with the falx itself, and then we go inside the tumor. So in the most cortical part again, with the aid of 5-ALA, we can do that, and you can see how we are identifying the cingulate sulcus. Let me show you one of the gaps of this contralateral approach, which is that we cannot access, we have no direct control of the superior part of the tumor, of the roof of the tumor cavity, but with the aid of the speculum or even an endoscope, we can reach that area. So you can see here how we have respected the cingulate sulcus and removed this anterior cingulum glioma. This is the aspect that the ipsilateral hemisphere has. After the removal, we can replace the files if we have it. If not, we can place some spongostan and close the dura. And with this contralateral approach, we can reach the most lateral part of these cingulate gliomas. Let's move more posteriorly. And let me show you this case, who is still in my ward because he came last week with some progressive hemiparesis due to the COVID. He was scared to go to the hospital, and he had some 25, 30 days progressive hemiparesis, and he came to the hospital in a very, very, very bad situation. So we did surgery on Friday, and let me show you that this tumor is mainly growing in the central aspect of the cingulate gyrus. So we can approach this tumor transcortical or transsulcal through the convexity because the tumor is quite close to that. But if we follow the rule of approaching and entering the tumor through the most cortical part, we will understand why. And let me show you the tractography. You can see in yellow the corticospinal tract. So if we go from lateral crossing this very thin layer of cortex, we will probably ending damaging this corticospinal fiber tract. So this is why I prefer to go interhemispheric, IPSI or contralateral, wherever you feel more comfortable with. I prefer contralateral in this case. So this is the scheme of the surgery we can perform for that. And we always perform this venography in order to check that the contralateral window is going to give us a good access to the interhemispheric fissure. So we can place in the contralateral side, which means in the side where the tumor is, some electrodes to check the corticospinal tract continuously during surgery. You can put it epidurally, as I did in this case, and then we can access the interhemispheric fissure in order to remove the tumor. You can see in the post-op T2 coronal how this very thin layer of cortex now is much, much, much wider, and the corticospinal tract is right there, and we check it with electrophysiology. Let's move a little bit more posteriorly, and this is not a glioma, this is a metastasis, which is mainly located, as you can see in the sagittal cut, in the posterior part of the cingulate gyrus. And this is a very important area because here the cingulate gyrus is going to join the isthmus. I'm going to go a little bit lateral, but here the most important thing is to consider how close this tumor is of the so-called paracentral lobule, which is part of the motor and sensory strip. So this is what we have to identify. And again, in this case, I decided to go contralateral to have a more wider control of the lateral aspect of that tumor. So again, take your time to release CSF, to disconnect the veins, respecting them, and to create space enough in order to expose faults. So once we have a good window, we go in the interhemispheric fissure. Sometimes we check it with the ultrasound or with the Doppler, and then we open the files. So here we are opening the files. We can see the tumor already there with the paracentral lobule. So the ascending or distal ramus of the cingulate sulcus is right there, and the tumor is coming to the surface. This is the key, to approach the tumor from the most cortical part. So we are dissecting the arachnoid so as to preserve the paracentral lobule, which is just above, and that's the metastasis. So once we have space enough, we start debulking. And again, in this case, it was quite cystic. We can use the speculum so to check that the superior part is quite clean. And this is what we are doing here. So let me show you 24 hours later how after the decompression and removing the tumor, the layer of cortex, which was 1.2 centimeters, now suddenly became 2.6. There is a lot of white matter fiber tracts in that area that we must try to respect. Let's move more posteriorly and basally. And this is a 45-year-old lady who came with some headache, and we had this MRI, and you can see here an intrinsic tumor mainly located in the so-called isthmus. This is a very important area because, as I told you here, the cingulate gyrus, which is purely in the midline, becomes the parahypocampal gyrus, which is a little bit more basal and mainly lateral because of the diencephalon in between both gyri. So this is an isthmic region, pivotal point in between the cingulate and parahypocampal. And this is the limit for the interhemispheric approach. Everything basal here, we cannot, or we should try to avoid an interhemispheric approach. What can we do to approach the isthmus? We can go transcortical through the temporal lobe, through the occipital lobe. We can go subtemporal, suboccipital, or we can go even in some cases, we can try to go supracerebral transtentorial, but in this case, we decided to, again, apply our rule to reach the isthmus from the interhemispheric fissure. Why? Look at this. This is the isthmus in the contralateral side. So if we put all the white matter fiber tracts that we will cross in case we go transtemporal, we will mainly damage all these optic radiations, which should be preserved because the patient was completely intact. So lateral position, ipsilateral approach, interhemispheric parietoccipital. Once we reach the splenium, we release some CSF, we place a cottonoid, and then we go directly to the isthmus. We start debulking this intrinsic lesion, and we want to enter the atrium. This is going to be our lateral limit. So you can see how we have entered the atrium. That's the lateral wall of the atrium. So those are the optic radiations, the fibers we want to avoid damaging. Once we remove the tumor, we have a nice view of the lateral ventricle temporal horn, and you can see how we are covering the visual primary area. Let's move to this different case. This is again a metastasis, and it's located in the parahippocampal gyrus. If you see the T2, you can identify the collateral sulcus just lateral to this metastasis. So this is not medial. As I said before, this is paramedially located lesion. So in these cases, we prefer to approach them subtemporally, or you can go transcortical. In this case, we went subtemporal so as to, again, follow our rule. So after opening the dura and drilling the middle fossa to have a basal exposure, we are going to release some CSF, and suddenly, just medial to the collateral sulcus, here we have this metastasis, which is coming to the surface. After debulking it, it was very easy to take it out, very comfortable. We did a nice removal. We were very happy, fast approach, safe approach, and we were happy with that result. We coagulated a little bit the dura, and then we can close it in a watertight fashion. I always place this spongostan layer. This is the post-op CT scan 6 hours later, and you can see what happened after this very, very easy, fast, and safe removal. Even if we are applying the best rules, we can have terrible complications like this subdural hematoma. Well, let's move to this special case. This is a patient who came with headache and some memory disturbances, and we can see a GBM which is likely to be inside the ventricle. This is a purely hippocampal tumor. So you can see in the T2 how the tumor is perfectly drawing the anatomy of the hippocampus. So very important, once we decide the approach, to remove it and to identify our anatomical limits. Anteriorly, the ankle recess, posteriorly, the atrium, superiorly, the choroidal fissure, and inferiorly, the tent. Medially, we will reach the basal cisterns, which is the point in which we will stop removal. In this case, I decided to go through the temporal lobe. I did not apply our rules, so I did a transcortical approach because the tumor was quite vascularized, so I was scared of performing a subtemporal exposure. So anteriorly, ankle recess, superiorly, we will have the choroidal fissure. These are the basal cisterns with the carotid artery, PCOM and anterior choroidal. We are debulking the ancus. Here we can see the tent and the third nerve. I'm uncovering the third nerve, and now we have to be careful with the fourth nerve. This is the ancus, and you can see how these small hippocampal arteries from P2 are feeding this hippocampal tumor. So once we identify our anatomy, our limits, we are sure that we remove that tumor. So we can see here a nice view of the carotid artery with the posterior communicating going to P1, P2, and the third nerve coming from the midbrain. So this is our medial limit, the basal cisterns, and we are sure that we reach the most deep part of this hippocampal tumor with this trans T2 approach. This is an interesting case of an 18 months baby who came with seizures. And here we can see a complex tumor which is in 3 different functional units. It's located anteriorly in the temporomesial pole, also invading the amygdala and the head of the hippocampus, as you can see in the first axial image. So it's in 3 different parts. So in these cases, our nightmare is to respect the Meyer's loop that you can see is very, very related with this tumor. So in these cases, we don't do the classic Transylvian because it's invading the temporomesial aspect. So after splitting a little bit the fissure and releasing some CSF, I go through the temporal pole. I do a transplanum polare approach through the superior temporal sulcus. So once we go deep there, we will reach the medial aspect, the lateral aspect of the cavernous sinus wall. And that means that we remove the most anterior part of that tumor. Then we move posteriorly to the amygdala and finally to the head of the hippocampus. And the medial limit again is the pia. This is a subpial approach. So you can see the third nerve right there behind the arachnoid. And this is the head of the hippocampus, which is the last part of this surgery. So let me show you and summarize what we have been discussing: subcallosal region, anterior, central, and posterior cingulate, isthmic region, parahippocampal gyrus, and the ancus. But sometimes we can have tumors like this, which are invading different regions. This is a GBM, which was invading the ancus, the amygdala, parahippocampal gyrus, and you can see also the hippocampus, and even, as you can see in the sagittal cut, invading the isthmus. So we were discussing about a single approach to remove this tumor, and we couldn't identify it. So we decided to go in 2 stages. First stage, supracerebellar transtentorial, so sitting position. This is how we place these patients. Then we open the tent, we check with the endoscope if our exposure is good enough and orient ourselves. This is the ambience and crural system in front. And this is the parahippocampal gyrus, exactly where the tumor is growing. So we are applying our rule in this case. So we start debulking, and we can also use the 30 degrees endoscope with the CUSA so as to reach the most basal part of this tumor. Then we are trying to go upwards to the isthmus. We couldn't get it. That's the crura of the fornix, that's the choroid plexus. This is the lateral ventricle, just to orient ourselves. That's the pulvinar thalamus. And then we are moving to the most anterior aspect of the temporal horn. So in the lateral wall, you can see the optic radiations. So we were not able to take the isthmus out. So 2 weeks later, we perform an occipital interhemispheric transtentorial approach. We open a little bit the tentorium here, and we have the last part of this tumor located in the isthmus. So with the combination of these 2 approaches, we can remove the parahippocampal component and also the isthmic component. And what we are trying to preserve are the optic radiations, which are just behind that part, that cover of the ependymal layer. So this is the glomus of the choroid plexus. This is the crura of the fornix, which was the most superior part of that tumor. And this is the post-op in which we can see that we approach it both areas with these 2 approaches combined. So just to summarize, these are the different approaches applied to the anatomy that we can use to approach limbic and paralimbic lesions. So we have to go, and we can go interhemispheric, ipsi or contralateral, doesn't matter, whatever you feel more comfortable with. We can go supracerebellar transtentorial to the parahippocampal regions, and generally we go transsylvian or transtemporal to the parahippocampal and hippocampal regions. But always keep in mind that we have to go through anatomical corridors, respect the surrounding structures, and try to perform anatromatic manipulation. So takeaway messages: limbic system is located in the medial aspect of the hemisphere in the interhemispheric fissure with a very special white matter arrangement. Never forget the relation with the falx, the interhemispheric fissure anatomy, arterial system, very important and mandatory. Try to respect the venous anatomy in case you can. Lateral exposure, in my opinion, is better because I have a better bimanual maneuverability, and we have the aid of the gravity to expose and open the interhemispheric fissure. And the contralateral transfalcine is a good approach in order to have a better control of the lateral aspect of the tumor, and we no need to deal with a sick hemisphere because we are opening the contralateral hemisphere. So thank you so much, and let me finalize with this slide in which we can see that we had a brain like the fishes, and mainly they have paleopallium. So they are mainly programmed with olfactory functions, mnesic functions, but mainly they react to fear and danger. Look at these 2 guys who were taking this fish. They catch it. They wanted a nice picture, but the fish has in his rhinencephalon the message to escape. So we did it, he did it, and the 2 guys couldn't control that one. And look at this guy, he has a huge telencephalon, huge neocortex. He wants to take some money from the bank, but then his movements are not coordinated, but he always has a good limbic system in order to escape. Thank you so much.
Thank you very much, Pablo. Thank you for an excellent talk. One of the questions that come up while you were speaking is they asked about, you talked very nicely about protecting the veins and draining CSF, and they asked about lumbar drainage. Do you use that at all in any of your operations?
Well, in these cases, I to be honest with you, I have never used it. I have thought it many times, but if you plan your surgery and your approach to have a wide access to any of the pericallosal cisterns, you can get CSF, release it. And if you cannot, in a few cases, what I have done is with the ultrasound, I just used the Cushing needle and took some CSF from the ventricles, which works very, very nice.
Excellent. Thank you very much. I think